Hello viewers, welcome to my channel. Today we will talk about tonsillitis. Tonsillitis is one of the favorite topics of examiners, and tonsillitis is frequently asked both in theory as well as in the practical exams of ENT. So I will try to simplify the topic as much as possible, and I hope you will like this video. So when we say tonsillitis, we are essentially talking about palatine tonsils. This automatically raises the question, are there other tonsils? Of course there are. There are nasopharyngeal tonsils, which we also know as adenoids. There are lingual tonsils, and there are tubal tonsils. Together, all these four form a ring-like aggregation of lymphoid tissue, which is known as Waldeur's ring. You'll also be probably surprised to know that there are tonsils in the brain as well, cerebellar tonsils lying in the posterior lobe of the cerebellum. But this discussion is only talking about palatine tonsils, which are also known as faucial tonsils. And if we use just the term tonsils, we are usually talking about palatine tonsils or faucial tonsils. So what are tonsils? They are a collection of lymphoid tissue. Tonsils essentially contain three layers: the surface epithelium, the crypts, which are about 12 to 15 in number, with the biggest crypt known as crypta magna or intratonsillar cleft. This is basically an invagination of the epithelium into the underlying lymphoid tissue. So there is the surface epithelium, the invagination of epithelium known as crypts, and the deep lying lymphoid tissue. These are the layers in every tonsil, palatine tonsil. Palatine tonsils are two in number, one on either side. Anteriorly, they are bounded by anterior pillar formed by the palatoglossus muscle. Posteriorly, they are bounded by palatopharyngeus muscle, which forms the posterior pillar. There is an upper lobe on the upper side, which is merging with or hidden under the soft palate. And there is the lower pole, which attaches to the base of the tongue. The medial wall of the tonsil is free, and the lateral wall of the tonsil is attached to the lateral oropharyngeal wall. Tonsils are essentially ovoid in shape, and most of the tonsil is not visible. It is hidden behind the anterior pillar. Okay, so now we know about what tonsil is. We also need to know what is the tonsillar bed made of. The tonsillar bed is made up of two muscles, superior constrictor muscle and styloglossus muscle. Remember the muscle styloglossus because this helps to understand what lies deep to the tonsillar bed: styloid process and glossopharyngeal nerve, which can be accessed deep to the tonsillar bed. Now, it is also very important to know what is the blood supply of the tonsils, what is the arterial supply, and what is the venous drainage. It is very important to know the arterial supply of tonsil because this helps us to understand why hemorrhage in tonsillectomy is such an important topic, because tonsils are supplied by major arteries. If you think of arteries, which artery do you think is the most important in the head and neck region? Of course, you will say common carotid artery. Common carotid artery bifurcates into external carotid and internal carotid. And you will be aware of the fact that internal carotid artery has no branches in the neck. So, of course, external carotid artery has branches in the neck. And what are the branches of external carotid artery in the neck? We have the superior thyroid artery, we have the ascending pharyngeal artery, lingual artery, maxillary artery, occipital artery, posterior auricular artery, superficial temporal artery, and of course, facial artery. I uttered these arteries in a very random order. There is a mnemonic for that, so you can follow that and you'll be able to utter the names in the particular order. So let's go in a particular order. Superior thyroid artery, ascending pharyngeal artery, lingual artery, facial artery, occipital artery, posterior auricular artery, maxillary artery, and superficial temporal artery. Now that I've uttered the names of the branches of the external carotid artery in the neck, which branches do you think will provide arterial supply to the tonsils? Will superior thyroid artery provide arterial supply to the tonsils? Unlikely. The tonsils are in the oropharynx, the thyroid is in the midline of the neck, quite far away. Will ascending pharyngeal artery provide arterial supply? Likely, because oropharynx, pharynx, possible. Lingual artery, tongue, tonsils, close, possible. Facial artery, face, tonsil, possible. Occipital artery, occipital, quite a distance away. Posterior auricular, posterior auricular, quite some distance away. Maxillary artery, again, maxilla, tonsil, quite close. And we have the superficial temporal artery, again, some distance away. So just by knowing the names of the branches of the external carotid artery, we can guess or we can remember which branches of external carotid artery will provide arterial supply to the palatine tonsils. So what are they? Maxillary artery, facial artery, lingual artery, and ascending pharyngeal artery. Now, these are the branches of external carotid artery which provide arterial supply to the palatine tonsils. But which branches of these arteries provide arterial supply? From the maxillary artery, we have the descending palatine branch. From the ascending pharyngeal artery, we have the tonsillar branch. From the facial artery, we have tonsillar artery and ascending palatine artery. And from the lingual artery, we have dorsal linguae branches. It's very important to not get confused between descending palatine, and ascending pharyngeal. Descending palatine is a branch of maxillary artery, ascending palatine is a branch of facial artery, and ascending pharyngeal artery is a direct branch of the external carotid artery. So just to repeat, tonsils receive arterial supply from maxillary artery by the descending palatine branch, from the ascending pharyngeal artery by its tonsillar branch, from the facial artery by the tonsillar artery and ascending palatine artery, and from the lingual artery by the dorsal linguae branches. So rich arterial supply, which explains why there is hemorrhage or why the hemorrhage in tonsillectomy is so notorious. It is notorious to an extent that it is classified into primary, secondary, and reactionary. Primary if it happens during the surgery, reactionary if it happens within 24 hours of surgery, and secondary if it happens beyond 24 hours after the surgery. Now, what is the venous drainage of palatine tonsils? Paratonsillar vein. Paratonsillar vein lies in the area of loose areolar tissue just lateral to the fibrous capsule. The epithelium of tonsil is non-keratinizing stratified squamous epithelium, but it does contain a fibrous capsule lateral to which is loose areolar tissue, which is the area of the paratonsillar vein, and this is also the area where pus collects in peritonsillar abscess. What is the lymphatic drainage of tonsils? Tonsils have lymphatic drainage by the lymphatics from tonsil pierce the superior constrictor muscle and drain into the upper jugulodigastric or level 2 lymph nodes in the neck. Finally, we talk about the nerve supply of the tonsils. Sensory supply to the palatine tonsils is from the glossopharyngeal nerve or the 9th cranial nerve and lesser palatine branches from the sphenopalatine ganglion, which receives branches from the 5th cranial nerve. So now that we've talked at length about the anatomy of tonsils, we should also spend some time to talk about the physiology of palatine tonsils. Palatine tonsils, or for that matter, any other tonsils in the oropharynx and the nasopharynx, play a role in local immunity. How do they play a role in local immunity? By surveillance mechanism and also by generating antibodies. How do tonsils generate antibodies? The germinal center contains B cells, B lymphocytes, which when they get stimulated turn into plasma cells, and these produce antibodies. Also, the mantle zone contains large lymphocytes which help in phagocytosis. Surveillance mechanism helps in preparing the immune system to fight against foreign intruders like bacteria, viruses, or other antigens. But it is important to remember that the main role that the tonsils play in immunity is from the age of 4 to 10 years. And with advancing age, the function of tonsils really is replaced or they undergo what we call involution. So tonsils no longer play an important role in immunity. So of course, it may raise the fear that if you perform tonsillectomy in a patient aged between 4 to 10 years, does it have an adverse effect on immunity? But no data so far, whether epidemiological or clinical, has provided any evidence that immunity is compromised if tonsillectomy or adenoidectomy is done in an age between 4 to 10 years. However, they should only be done in specific situations, that is specific indications, and we will talk about that later in the video. Now that we have talked about anatomy of tonsils and physiology of tonsils, we have to talk about tonsillitis. Tonsillitis can be acute and it can be chronic. We will first talk about acute tonsillitis. Acute tonsillitis usually presents with the following symptoms. sore throat, difficulty swallowing, fever. Fever may be 38 to 40 degrees Celsius, may even have chills and rigors, and there can be children who just present with fever and only on examination one notices enlarged tonsils. Patient can also have pain in the ear. This pain in the ear can be referred pain through the tympanic branch of glossopharyngeal nerve, or it can be acute otitis media, which is one of the complications of acute tonsillitis. Patient may also have constitutional symptoms such as headache, generalized body ache, malaise, and constipation. Usually, the constitutional symptoms of tonsillitis are more severe than the constitutional symptoms associated with pharyngitis. Patient may also have abdominal pain due to mesenteric lymphadenitis, and an acute tonsillitis patient presenting with abdominal pain can create a picture of acute appendicitis. Such can be the abdominal pain, but this is due to inflammation of lymphoid tissue. If lymphoid tissue can undergo inflammation in the oropharynx, it can also undergo inflammation in the mesentery. So please don't get confused between acute tonsillitis and acute appendicitis, because the treatment is markedly different, to say the least. Now, what are the signs that you can see? Signs, of course, are things that the doctor notices, whereas symptoms are what the patient complains of. In signs, you might notice fetid odor, that is foul odor from the mouth. You may notice white coated tongue. Now, how do you perform physical examination in tonsillitis? You have to ask the patient to open their mouth, of course. But the oral cavity is a dark cavity, so you need light. This light can be obtained by wearing a headlight, where the light comes out of the forehead, or you can wear a head mirror, and then the light from a bullseye lamp will be reflected from the head mirror and should fall in the area of interest. But this is not enough. You also need a lax tongue depressor. The curved end of the lax tongue depressor will be held in the non-dominant hand or the dominant hand. That doesn't really matter. And you should place the tip of the tongue depressor. Actually, preferably use the dominant hand. Why not use the dominant hand? The tip of the tongue depressor should be placed at the junction of anterior 2/3 and posterior 2/3 of the tongue to depress the tongue so that you get a good view of the tonsils. What may you see? You may see hyperemia or redness of the uvula, of the soft palate, of the anterior pillar. These can be seen, and of course, the tonsils themselves can be enlarged. Now, enlarged tonsils can be graded according to Brodsky classification, where grade 0 is when tonsils are not visible, grade 1 is when the tonsils have not crossed the posterior pillar, grade 2 is when tonsils have crossed the posterior pillar but not more than 50% of the distance from the posterior pillar to the uvula. Grade 3 is when the tonsils are enlarged and have crossed more than 50% of the distance between the posterior pillar and the uvula. And grade 4 is when the tonsils are touching each other, also known as kissing tonsils. Now, this is about the enlargement of the tonsils, but the appearance of the tonsils also helps in characterizing whether it is acute catarrhal tonsillitis or acute superficial tonsillitis, in which case tonsillitis is present in association with pharyngitis and usually is due to a viral infection. How do you understand there is pharyngitis? You basically have to compare the color of the posterior pharyngeal wall with the appearance of the soft palate. If it is different, then usually it is pharyngitis, but it is not so simple. I have oversimplified it here. So if there is pharyngitis as well as tonsillitis, you should think of acute catarrhal tonsillitis or acute superficial tonsillitis, where only the superficial epithelial layer is affected. If the crypts are also affected, then pus or purulent material can accumulate in the crypts and can present as yellowish spots on the tonsil. This is known as acute follicular tonsillitis. The next stage of acute follicular tonsillitis is when the purulent spots fuse to coalesce into a membrane, which is white in color. This is called acute membranous tonsillitis. And if the infection reaches the lymphoid tissue or the substance of the tonsil, it is called acute parenchymatous tonsillitis, where the tonsil is uniformly engorged and congested. Usually, if there is kissing tonsillitis, it is seen in cases of acute parenchymatous tonsillitis. Apart from this, there can be features in the neck as well. As you know, lymphatic drainage of tonsil is to the level 2 lymph nodes. So these lymph nodes at the level 2 or upper jugular digastric region can be enlarged and tender. Now, what are the complications of acute tonsillitis? Acute tonsillitis can, of course, lead to chronic tonsillitis, which is the most important complication. Because of unresolved acute tonsillitis, the infection can persist in the lymphoid tissue in the tonsils. This can lead to chronic tonsillitis. Acute tonsillitis can lead to acute otitis media. Acute tonsillitis can also lead to some abscesses like peritonsillar abscess, parapharyngeal abscess, and cervical abscess, especially in the level 2 region. Now, tonsillitis typically is caused, can be caused by virus or it can be caused by bacteria. In the bacteria, the most common bacteria causing tonsillitis is hemolytic streptococcus. It can also be caused by staphylococcus or pneumococcus or even Haemophilus influenzae, but hemolytic streptococcus is the most commonly encountered agent in terms of the cause of bacterial tonsillitis. Now, streptococcal infection of tonsils can also lead to other manifestations in the body, like rheumatic fever, like bacterial endocarditis, like post-streptococcal glomerulonephritis, which are all due to streptococcal infections. So these are all complications of acute tonsillitis, which is possible. But remember that chronic tonsillitis is also a complication of acute tonsillitis. Now, let's talk about the differential diagnosis of membrane over tonsil. If you notice a membrane over tonsil, it can be 10 things. And you can understand that on the basis of history, on the basis of physical examination, on the basis of ordering the right investigations like total WBC count, differential leukocyte count, blood smear, throat swab for culture, bone marrow aspiration, needle biopsy, special tests like Paul Bunnell test or even excision biopsy. And we'll get to it one by one. But let's talk about the 10 possible diseases that can produce membrane over tonsils and how we understand which one is what. Number one possibility of membrane over tonsil, a disease causing membrane over tonsil, is of course acute membranous tonsillitis. In this situation, the membrane is white in color. There will be the features of tonsillitis that I have already described. And this white membrane can be easily wiped away. So then you think the disease is acute membranous tonsillitis. If this membrane is dirty gray in color, if it is not restricted to tonsil, it grows to reach the soft palate and the uvula. If the symptoms are not as acute in onset as acute membranous tonsillitis, if they are gradual in onset and not as marked as acute tonsillitis, and most importantly, if the membrane is adherent to the tonsil, very difficult to remove, and if you remove it, it reveals a bleeding tonsillar surface, then suspicion of diphtheria should be there. And you can confirm your suspicions by performing a throat swab and sending it for culture sensitivity, sending it for culture. If you send the throat swab for culture, you will find growth of Corynebacterium diphtheriae. You can also find albumin in the urine. So of course, if you find Corynebacterium diphtheriae in the throat swab culture, then the diagnosis of diphtheria is confirmed. Then you have to treat diphtheria. So this is the second possible explanation of membrane over tonsil, diphtheria. The third explanation, or the third possibility, if there is a membrane over palatine tonsil, is if the membrane can be easily removed and it reveals an ulcerative surface over the tonsil. And these ulcerations are also present in other parts of the oropharynx. This can be due to Vincent angina. Vincent angina is also insidious in onset, and the symptoms are not as pronounced as acute membranous tonsillitis. And here also you can send throat swab culture where you will find growth of the responsible organisms like spirochetes and fusiform bacilli. If the symptoms are as pronounced or even more pronounced than acute membranous tonsillitis, and they do not show any improvement with antibiotic therapy, then you have to start thinking about infectious mononucleosis, which is caused due to Epstein-Barr virus infection. Here also the tonsils are engorged, there is white cheesy exudates, and there is lymph node enlargement typically in the posterior triangle or the level 5. Patient does not show any improvement with antibiotics, and only then usually the suspicion is raised. In the first week, the blood investigation reports would usually be normal, but the blood smear can show up to 50% lymphocytes, of which 10% may be atypical cells. Typically in the second week, the white blood cell count starts to rise. How do you confirm the diagnosis of infectious mononucleosis? By performing a special test known as Paul Bunnell test, also known as monospot test, where we notice increased titer of heterophile antibodies. So now we have found so many causes. How many? Let us revise. Acute membranous tonsillitis, diphtheria, Vincent angina, infectious mononucleosis. We found 4. Fifth cause can be agranulocytosis. In agranulocytosis, again, you see ulcerations in the oropharynx, and typically we diagnose this by performing blood investigations, where we can see that in the acute fulminant form, leukocyte count falls below 2000 per cubic millimeter and may even be less than 50 per cubic millimeter. In the chronic form or the less fulminant form of agranulocytosis, the leukocyte count can fall up to 2000 per cubic millimeter. So agranulocytosis is detected by the sharp decline in leukocyte count. Again, the opposite side of the spectrum, if leukocytes are enlarged or increased, much increased in number, up to 1 lakh per cubic millimeter, then you think of a disease known as leukemia, which can also present with membrane over tonsil, and it is also associated with anemia. So you will also find anemia in these patients. If there is membrane over the tonsils with anemia and leukocyte count is up to 100,000 per cubic millimeter, 1 lakh per cubic millimeter, then you can think of leukemia, especially in children where lymphoblastic leukemia is seen in up to 75% cases of leukemia. Now that we've talked about leukemia, we can also talk about malignancy of tonsil. Malignancy of tonsil also may present with a membrane over the tonsil, and you can only confirm the diagnosis by performing excision biopsy of that particular tonsil. Now, what are the other causes? There can be aphthous ulcer. Aphthous ulcer also presents with membrane over the tonsils, and the predominant symptom here is that of pain. Aphthous ulcer is extremely painful. Even if it is small in size, it can be multiple also, but pain is always extreme. It can present on the anterior pillar or on the tonsil itself, but membrane over tonsil with excruciating pain should raise the suspicion of aphthous ulcer. Traumatic ulcer can also produce a membrane over the tonsils because any trauma to the tonsil, say by a toothbrush or by a pencil held in the mouth or any other cause, usually heals with the formation of a membrane within 24 hours. And the final cause that I can think of which can produce a membrane over the tonsil is candidal infection or fungal infection of the tonsil. So what are the causes of membrane over tonsil that we have talked about here? First, acute membranous tonsillitis, diphtheria, Vincent angina, infectious mononucleosis, agranulocytosis, leukemia, malignancy of the tonsil, aphthous ulcer, traumatic ulcer, and candidal infection of the tonsil. Now, how do we treat the acute tonsillitis? Now, imagine if it is acute tonsillitis due to bacterial cause, then you have to encourage the patient to lie down, take rest, take plenty of fluids, prescribe analgesics and antibiotics. Which antibiotic will you prescribe? Because most commonly bacterial tonsillitis is due to streptococcal infection, then you can prescribe penicillin as the drug of choice. If the patient has allergy to penicillin, you can switch to erythromycin, and typically it needs to be prescribed for 7 to 10 days. In viral causes of tonsillitis, you don't need to prescribe any antibiotics unless, of course, there is suspicion of superadded bacterial infection. Now, if the cause is something else, like diphtheria or malignancy, then of course you have to treat accordingly. So, this is the medical management of acute tonsillitis. If this does not resolve, or there are repeated episodes of acute tonsillitis and it leads to formation of chronic tonsillitis, then if medical treatment is not proven to be sufficient, then you have to go for surgical treatment. But this has specific indications. Tonsillectomy is the surgery performed for treatment of chronic tonsillitis that is not responding to treatment, and it has the following indications, which are subclassified into absolute indications of tonsillectomy, that is, you have to perform tonsillectomy in these situations, relative indications of tonsillectomy, and tonsillectomy as a part of a different procedure. Let's discuss them one by one. There are 5 absolute indications of tonsillectomy. Number 1 is if there is suspicion of malignancy. In that case, you have to perform tonsillectomy and send the tissue for biopsy to confirm whether malignancy is present or not. Number two is when the tonsil is enlarged to an extent that it is causing airway obstruction, like obstructive sleep apnea, or it is interfering with speech, or it is producing difficulty in swallowing or difficulty in deglutition. As I mentioned here, the symptoms of acute tonsillitis are fever, sore throat, difficulty in swallowing, ear pain, and constitutional symptoms like headache, body ache, malaise, and constipation. So let's come back to absolute indications of tonsillectomy: suspicion of malignancy, tonsillar hypertrophy, which is producing obstruction in airway like sleep apnea, or interfering with speech, or producing difficulty in deglutition. The third absolute indication of tonsillectomy is tonsillitis producing febrile seizures. If tonsillitis produces febrile seizures, then that is an absolute indication of tonsillitis. Coming back to peritonsillar abscess, which is also known as quinsy, peritonsillar abscess may also prove to be an absolute indication for tonsillectomy, but it is different in children and adults. Tonsillitis is rarely seen in infants, and it is also rarely seen in patients above 50 years of age, but it can be seen in the age group beyond infancy and up to 50 years of age. If peritonsillar abscess, which is a complication of both acute tonsillitis and chronic tonsillitis, is seen in children, then you should perform tonsillectomy 4 to 6 weeks after the first episode of peritonsillar abscess. However, in adults, you should wait for the second episode of peritonsillar abscess. If there are more than one episodes of peritonsillar abscess, then you should perform tonsillectomy. That becomes an absolute indication of tonsillectomy. Finally, we come to the most famous absolute indication of tonsillectomy, which was found in the Paradise criteria, which is a paper that was published, I believe, in the 1980s, which established the number of recurrent episodes of tonsillitis that need to be fulfilled, or that need to happen to fulfill the criteria of absolute indication of tonsillectomy. How many times should a person have tonsillitis to actually need tonsillectomy? Because of course you can prescribe antibiotics and that can help in the resolution of the symptoms, but after a certain number of instances, one needs to look at surgical treatment. So what are the number of episodes? That was clearly mentioned in this particular study. So what do we find here, and how do we remember this? Remember three numbers: 1, 2, and 3. And we have to match these numbers with the number of episodes. So 1 talks about 1 year. In 1 year, there should be at least 7 episodes of tonsillitis. Okay. In each of the last 2 years, there should be at least 5 episodes of tonsillitis. In each of the last 3 years, there should be at least 3 episodes of tonsillitis. And finally, if due to tonsillitis, patient misses out on up to 2 weeks of school or 2 weeks of leave from work, then it can be considered an absolute indication of tonsillectomy. So recurrent episodes of tonsillitis, there is at least 7 episodes in the last 1 year, at least 5 episodes in each of the last 2 years, and at least 3 episodes in each of the last 3 years. And up to 2 weeks in a year of school or work missed due to tonsillitis also constitutes absolute indication of tonsillectomy. Now let's talk about the relative indications of tonsillectomy. Here we have 2 features where we have streptococcal carriers. If a patient has valvular heart disease and is having recurrent episodes of streptococcal tonsillitis, then that is a relative indication of tonsillectomy. If a patient is a streptococcal carrier and is not responding to antibiotic therapy, then also there is a relative indication of tonsillectomy. If a patient has bad breath, that is halitosis, and that is not responding to medical management, that also constitutes a relative indication of tonsillectomy. Also, diphtheria carriers also are a relative, they also fulfill the relative indication of tonsillectomy. If someone is a diphtheria carrier, that is also a relative indication of tonsillectomy. So you don't definitely need to perform, but you can perform tonsillectomy in these patients. Now we think of tonsillectomy as a part of a different procedure. So you're trying to do something else, but to perform that surgery, you also need to perform tonsillectomy first. Which surgeries can these be? Of course, if you need to remove the tonsil to reach something else, those surgeries will require tonsillectomy as a part of those procedures. So what lies beyond the tonsillar bed, deep to the tonsillar bed? We have the styloid process and we have the glossopharyngeal nerve. Now, if styloid process gets elongated due to excessive calcification, it produces pain in the tonsillar region. This disease is called Eagle syndrome or stylalgia, which can be surgically managed by removing the excessive or the elongated part of the styloid process. In order to reach the elongated part of styloid process, you have to remove the tonsil first. That is, you have to perform tonsillectomy first and then dissect through the tonsillar bed to reach the styloid process and remove the elongated part. Also, in glossopharyngeal neurectomy, to reach the glossopharyngeal nerve, you have to perform tonsillectomy first. And finally, in obstructive sleep apnea, there is a procedure known as uvulopalatopharyngoplasty. In that procedure, also tonsillectomy forms a part of the broader procedure of uvulopalatopharyngoplasty, which is the surgical treatment of obstructive sleep apnea. Now, there are contraindications of tonsillectomy, there are steps of tonsillectomy, there are complications of tonsillectomy. All of that we will not discuss in today's video. So in this video, we talked about the anatomy of palatine tonsils, the physiology of palatine tonsils, the signs and symptoms and complications, and the approach to treating a patient of acute as well as chronic tonsillitis. Just to recap, the complications of acute tonsillitis are acute otitis media, acute post-streptococcal glomerulonephritis, rheumatic fever, bacterial endocarditis, peritonsillar abscess, parapharyngeal abscess, and cervical abscess. All of these things are also possible in chronic tonsillitis except acute otitis media. Acute otitis media is not possible in chronic tonsillitis. However, there are some unique complications for chronic tonsillitis as well, such as tonsilloliths, that is stone formation in the palatine tonsils, and tonsillar cysts. So we have talked about signs, symptoms, complications, how to treat medically, how to treat surgically, when to treat surgically, how to how to understand the different possibilities or developing the differential diagnosis for membrane over tonsils. And I guess I have been able to be both comprehensive as well as I have been able to simplify this topic. This is a very important topic, especially for MBBS ENT students. And I hope you liked watching this video. If you have any questions, if you have any doubts, if you found any inaccuracies, please don't hesitate to reach out in the comment section. Thank you so much for watching this video. Take care. Bye-bye. And please don't forget to be awesome.